Imagine, imagine paying like $2,000 to trigger your body's ultimate healing response.
Right, which is a serious investment.
Exactly. You go to a clinic, you have your blood drawn, you sit through that whole centrifuge process to isolate the growth factors.
Yeah, the PRP.
Right. And then you undergo a series of, well, pretty intimate injections. You're investing serious money and, let's be honest, physical discomfort into this regenerative treatment.
Oh, absolutely.
Then the next morning, you wake up feeling a little tender. So to take the edge off, you just swallow a single over-the-counter Advil.
Which people do all the time without thinking.
Yeah, and without even realizing it, you completely shut down the entire biological cascade. You literally just paid a premium to start.
It is a massive pitfall. I mean, it's one of the most surprising pharmacological interactions we see in the clinical data for this.
That interaction is just one piece of the puzzle we're looking at today. So welcome to the deep dive.
Glad to be here for this one.
Our mission for this session is highly specific for you today. We're looking at a huge stack of clinical guidelines, aesthetic clinic brochures, and detailed medical reviews.
Yeah, a lot of conflicting material in there, honestly.
Right. And we're trying to answer two incredibly common yet widely misunderstood questions about the O shot or vaginal PRP. First, how long do the results actually last?
Which is what everyone wants to know.
Exactly. And second, what kind of maintenance schedule are you realistically signing up for?
Because the clinical reality found in these documents paints a much more nuanced picture than what those glossy marketing brochures might tell you.
Yeah, since we already know the mechanics of PRP, drawing a small amount of your blood, spinning it down to harvest the concentrated platelets, and injecting them back to improve sensitivity and tissue health, our focus today isn't on the what.
Right, we're focusing purely on the when.
Exactly. You read these brochures from places like Optimal Medical Group or Elite Aesthetics, and there's this unspoken expectation of a quick fix.
Sure, because we're just so conditioned to want immediate returns on our investments, right?
Totally. But biology refuses to be rushed.
It really does. I mean, this treatment relies entirely on your body's own localized healing response. The timeline isn't just a standardized guarantee you can stamp on a calendar.
Right.
It's a biological process, and that's dictated by your individual cellular health, the severity of your symptoms, and, crucially, your underlying hormonal environment.
So before we can even talk about how long the results last, I guess we have to look at when they actually start.
Yeah, let's start there.
The sources talk about the immediate aftermath, like the first 24 to 72 hours. Patients report mild discomfort, maybe some swelling, or distinct warm sensation in the treated area.
Yeah, and a few sources even describe a feeling of fullness.
Right, but that initial fullness is often mistaken for the actual regenerative result, isn't it?
Oh, all the time. But it's purely mechanical. I mean, you've just injected a volume of liquid plasma into delicate tissue, so naturally, it's going to be plumper. Makes sense. Think of it like a biological construction site. That initial swelling is really just the delivery trucks arriving and dropping off the raw materials.
So the trucks have arrived, but nothing has actually been built yet.
Exactly. The real work hasn't even started. When those highly concentrated platelets are injected, they act like a localized distress signal.
Wow. Okay.
Yeah, for up to 7 days post-injection, they just sit in that tissue, releasing growth factors. In our construction analogy, the platelets are basically the foremen standing on site, handing out blueprints and blasting a siren to wake up your body's local stem cells.
So checking the sources, they show patients in clinical trials reporting early changes within 1 to 2 weeks, like a slight uptick in natural lubrication.
Right.
But then the data shows this really strange dip. Patients might feel a burst of improvement, and then it just seems to taper off entirely before slowly building back up. What causes that plateau?
So that dip is the physical volume of the plasma being naturally absorbed by the body.
Oh, I see.
Yeah, the liquid that caused that initial mechanical plumpness just dissipates. It fades away, which can totally feel like a step backward to a patient.
I'm sure people get panicked when that happens.
Oh, absolutely. But the actual biological effect is quietly ramping up underneath. The stem cells are finally following those blueprints.
Right, they're getting to work.
Exactly. They're actively engaging in angiogenesis, which is the formation of brand new microblood vessels, and neurogenesis, which is regenerating the nerve endings.
Building the actual scaffolding and plumbing, basically.
Yes. The lasting functional effects,
Yeah.
the increased sensitivity, improved continence, structural integrity, all of that comes exclusively from those newly grown cells replacing the absorbed plasma.
But if the scaffolding takes that long to build, when do you actually see the finished product?
Well, the consensus across multiple sources is remarkably consistent on this, whether you look at aesthetic clinic reviews or the clinical trials cited by the Women's Health Clinic.
And what do they say?
Peak cellular regeneration develops around the 2 to 3 month mark.
Wow, 2 to 3 months.
Yeah, and some conservative guidelines even suggest waiting up to 4 months before judging the final outcome.
So you are basically signing up for a massive ramp-up phase, like 3 months of pure patience before you can truly evaluate if the intervention gave you the relief you paid for.
It really requires a major shift in expectations right from the moment a patient walks through the clinic door.
Okay, so let's assume we've hit that 3-month mark.
Okay.
The construction is finished, the new blood vessels are functioning perfectly, the stress incontinence when you sneeze is gone, the sensitivity has returned.
The ideal scenario.
Right. How long do you actually get to enjoy this before the new tissue starts to degrade?
So we look at the longevity window next. And again, we see a strong clinical consensus across sources like Jandaly plastic surgery and other aesthetic guidelines.
And the timeline is?
The functional results typically hold for anywhere between 12 to 18 months.
Okay, 12 to 18 months. Though I did see a few patient reviews mentioning benefits stretching up to 2 years.
Yeah, that happens, but 12 to 18 months seems to be the firm clinical expectation.
Which begs a rather massive question, honestly.
What's that?
If my body went through all the trouble of growing brand new blood vessels and synthesizing fresh collagen, why do those new structures eventually fade away at all?
Right. Well, we have to look at the environment those new structures were built in.
Because the body is still aging.
Yes, the body continues to age. But more specifically, the literature points us toward a condition detailed in the Women's Health Clinic source. It's called genitourinary syndrome of menopause, or commonly referred to as GSM.
Okay, GSM. And that encompasses a whole host of symptoms, right? Like vaginal atrophy, chronic dryness, pain during intimacy.
Exactly. And the clinical report notes that because of the persistent hypoestrogenic environment associated with GSM, there is a natural, unavoidable attrition of the newly regenerated tissue over time.
Wait, let's translate persistent hypoestrogenic environment for a second.
Sure.
That essentially means the body is chronically starved of estrogen.
Precisely. Estrogen is the primary hormone responsible for keeping vaginal and vulvar tissue thick, elastic, and richly supplied with blood.
So without it.
When those hormone levels plummet during perimenopause and postmenopause, the tissue structurally thins out and loses its blood supply. That is the literal definition of atrophy.
But wait, if the underlying issue causing the tissue to degrade is a systemic lack of hormones, I have to push back on this entire procedure.
Okay, let's hear it.
Isn't injecting PRP just putting a very expensive temporary Band-Aid on a gaping wound? I mean, if the foundation of a house is crumbling because the soil is giving way like the estrogen drop, why are we spending thousands of dollars repainting the living room with growth factors?
That is such a critical pushback, and it's one that the medical sources actually anticipate.
Oh, really?
Yeah, the guidelines are very explicit on this front. PRP does not and cannot replace hormone replacement therapy. It is heavily categorized as an adjunct treatment.
Okay, so it's a complementary tool, not a substitute.
Exactly. PRP is incredibly effective at forcing the body to build new cellular infrastructure and repair nerve damage locally.
Right.
But if the root cause of the tissue degradation is a systemic hormonal deficiency, the localized PRP injection cannot magically fix the systemic issue. For patients dealing with severe menopausal atrophy, the root cause must be managed concurrently.
Meaning, you might build a beautiful new network of blood vessels with the O shot. But if you don't support it by addressing that hostile hormonal environment, those new vessels are just going to starve.
Yes, they'll wither much faster than that 18-month timeline.
Wow.
If the underlying environment remains hostile, the regenerative effects will face accelerated attrition and bring the patient right back to their original baseline.
Well, this directly impacts the calendar then. If the results are supposed to last 12 to 18 months under good conditions, then the maintenance schedule should logically be a simple annual visit to the clinic.
Right, like booking a dental cleaning.
Exactly. You go in, get a top-up, and go about your year.
That would be the assumption, yeah.
But the source material contains a massive, glaring contradiction regarding when a patient actually needs to return.
Oh, definitely. It's all over the place.
Yeah. One aesthetic clinic suggests that simple annual top-up. But then you look at Optimal Medical Group, and their literature explicitly recommends repeat treatments every 4 to 6 months to maintain optimal results.
Which is a huge discrepancy in both time and money.
And it gets even more confusing. The Women's Health Clinic document outlines a standard clinical protocol of 3 to 4 sessions spaced just 4 weeks apart.
Right.
Plus, in our stack, there's a patient review from a woman dealing with a severe autoimmune skin condition called lichen sclerosis.
Oh, I saw that one.
She noted her doctor advised a second treatment almost immediately after her first, specifically citing the severity of her tissue damage. So we have 4 weeks, 4 months, and a full year. Which one is the actual clinical truth?
Well, surprisingly, they are all clinically accurate.
Wait, really?
Yeah.
How?
It's incredibly confusing if you view those schedules as applying to the exact same type of patient. To untangle this, the sources require us to differentiate between 3 distinct clinical phases:
Okay, what are they?
the initial loading phase, the severity of the baseline symptoms, and the long-term maintenance phase.
Let's break those down with some profiles so we can picture it. Let's start with a relatively healthy patient, maybe in her late 30s, experiencing some mild changes in sensitivity or very minor stress incontinence after childbirth.
Okay, so for that specific profile, the patient is basically looking for a mild regenerative boost. Her baseline tissue health is already structurally sound.
So what does she need?
A single O-shot might be perfectly sufficient. She undergoes the procedure, experiences that cellular peak at the 3-month mark, and enjoys the functional results for a year to 18 months.
Before deciding if she even wants an annual top-up.
Exactly. That perfectly fits the one and done for a year model.
Okay, but now contrast that with the patient mentioned in the review suffering from lichen sclerosis, or a patient with severe postmenopausal tissue atrophy.
Right, which is a completely different baseline. Lichen sclerosis causes aggressive scarring, fusing, and severe thinning of the vulvar skin.
So a single injection of platelets just isn't going to reverse severe chronic structural damage like that.
Not a chance. Her starting baseline is in a deep deficit, and this is where the loading phase comes in.
Oh, okay.
That protocol describing 3 to 4 sessions spaced 4 weeks apart, that is not a maintenance schedule.
It's not.
No, it's an intensive, front-loaded effort to build a foundation of healthy tissue from scratch.
Oh, I see.
The clinician administers a shot, waits a month for the initial growth factors to stimulate angiogenesis, and right before the damaged tissue can regress, they hit it again with another wave of PRP. They are actively compounding the regeneration.
I have to pause on the financial and emotional toll of that, though. I mean, at roughly $1,500 to $2,000 a session, you're telling me a patient with severe atrophy or lichen sclerosis might have to drop $6 to $8 grand over 3 months just to hit a normal baseline.
Unfortunately, yes.
Before they even reach a maintenance phase.
Yeah.
Does the clinical literature actually justify that kind of massive upfront burden?
Well, the clinical justification rests on the fact that for these severe conditions, standard first-line therapies, things like topical steroids or basic moisturizers, have often completely failed the patient.
Okay, that makes sense.
So the intensive PRP loading phase is viewed as a significant medical intervention to halt disease progression and restore basic function, rather than just an elective aesthetic enhancement.
Right.
However, the guidelines are very strict about monitoring this investment.
Actually, yeah, the Women's Health Clinic source highlights this perfectly. They stress that a clinical review at the 3 to 6 month mark is non-negotiable.
Absolutely non-negotiable.
The document literally states, if expected improvement does not occur, the plan should be reviewed rather than repeated automatically.
Because a responsible clinician will not blindly schedule a 4th or 5th expensive injection if the first 3 haven't moved the needle.
Right.
They have to stop and reevaluate the diagnosis. Perhaps the incontinence isn't a tissue issue. Maybe it's purely a severe pelvic floor muscle deficit that PRP just cannot fix.
So the maintenance schedule is entirely bespoke.
Very much so.
Once that severe patient has built a healthy baseline of tissue over a few months of intensive loading, they finally shift into a maintenance phase.
Right. And depending on how aggressively their underlying autoimmune or hormonal condition fights back, their ongoing maintenance might need to be every 4 to 6 months.
Rather than the healthy patient's annual visit.
Exactly. It all comes down to the quality of the soil you were starting with and how hostile the environment is to new growth.
This financial reality brings up a massive point. If a patient is investing this much capital and physical vulnerability into a treatment that explicitly relies on their own baseline health, the burden shifts heavily to what happens when they walk out the clinic door.
Oh, totally.
How do they maximize that investment to ensure they actually reach that 18-month mark?
It becomes entirely about fostering the internal environment. You have to give those newly signaled stem cells the best possible chance to thrive.
Which brings us back to the warning I mentioned at the very beginning of the deep dive, the NSAI revelation.
Yes.
The NSAIDs. The clinical guidance states in bold lettering that patients must absolutely avoid nonsteroidal anti-inflammatory drugs like ibuprofen, Advil, Aleve, or aspirin for 7 days before and at least 7 days after the procedure.
It's so important.
But why does a common headache pill ruin a $2,000 treatment?
It comes down to the chemical mechanism of how NSAIDs reduce inflammation in the body. They don't just mask pain, they work by inhibiting specific enzymes, which in turn chemically alters platelet function. NSAIDs literally deactivate the platelet's ability to aggregate and signal.
So you pay a clinic to painstakingly isolate and concentrate your platelets so they can release growth factors, and then you swallow an ibuprofen that chemically turns those exact platelets off.
Yep. You halt the regenerative cascade before the stem cells even get the blueprints.
That is wow.
If a patient requires pain management post-procedure, the literature advises consulting their provider for alternatives like acetaminophen, which processes differently and doesn't inhibit platelet function in that same destructive way.
It is a devastatingly simple mistake to make if you aren't warned.
Definitely.
But beyond avoiding NSAIDs, the sources highlight several lifestyle factors that heavily influence longevity too. Maintaining systemic hydration, engaging in regular cardiovascular exercise, and crucially, avoiding smoking and chronic high stress.
Because smoking and high cortisol levels actively constrict blood vessels. If you are relying on your body's blood flow to heal delicate tissue, you simply cannot simultaneously engage in habits that choke off that exact blood supply.
Makes perfect sense. We also see a very strong push in the aesthetic literature toward a multimodal approach, right?
Oh, yes. The stacking method.
Sources like Elite Aesthetics frequently mention stacking the O-shot with other cutting-edge clinical technologies to stretch out the results.
Well, think about it. PRP is a cellular treatment. It addresses blood flow and nerve health.
Okay.
But what if the surrounding tissue suffers from severe structural laxity? Or what if the underlying pelvic floor muscles are profoundly weak? Platelets cannot perform a muscle workout.
Right. So the sources mention combining the injection with radiofrequency devices using names like Ultrafem 360 or Morpheus 8VB.
Exactly. Those devices utilize targeted heat energy to physically tighten the tissue and stimulate the contraction of existing collagen from a completely different structural angle than the PRP.
They also mention combining the treatment with the mCella chair, which uses highly focused electromagnetic energy to induce thousands of supermaximal pelvic floor muscle contractions in just a single session.
And you can really see the synergy of the multimodal approach there. The electromagnetic chair builds the foundational muscle. That deep muscle pumping drives massive amounts of blood flow right up into the tissue.
Feeding the area.
Yes, that fresh blood flow supports the new microvessels and nerves that the O-shot just triggered. And then the radiofrequency devices tighten the outer structural envelope, holding it all together.
So you add in the management of systemic hormones to ensure the new tissue isn't starved of estrogen, and you have a comprehensive 360-degree strategy for longevity.
You aren't just relying on a single syringe to do all the heavy lifting. It is the ultimate expression of maximizing the clinical investment.
Well, looking across this massive stack of guidelines and reviews, the key takeaways regarding the timeline and maintenance of vaginal PRP become incredibly clear for anyone considering it.
They really do.
First, you have to abandon the expectation of instant gratification. You're entering a biological ramp-up phase where the cellular regeneration won't truly peak until the 2 to 3 month mark.
Right, patience is mandatory.
Second, the longevity window is finite. Once you hit that peak, the functional results typically last roughly 12 to 18 months, though this is heavily dependent on mitigating conditions like that hypoestrogenic environment of menopause we talked about.
And third, the maintenance schedule is fundamentally personalized.
Exactly.
It ranges from an intensive initial loading phase of monthly sessions for severe structural deficits, all the way down to a simple annual tune-up for a healthy patient just looking for a mild boost.
You have to work closely with a clinician who actually assesses your specific baseline, and you have to protect your investment. Avoid those NSAIDs, manage your lifestyle, and consider complementary therapies that address muscles and hormones alongside the cellular regeneration.
Because ultimately, while the procedure is fascinating because it leverages your own biological healing mechanisms, it isn't magic.
No, it's not.
Which leads us to a final underlying truth found in all of this literature. The entire premise of regenerative medicine relies entirely on the quality of your own blood.
Yeah, the clinic is merely concentrating the biological materials you bring to the table.
Exactly. They can't extract and inject cellular health that you don't already possess.
Oh, wow.
This raises a profound consideration for anyone looking into these treatments. Could optimizing your systemic everyday health, like improving your daily diet, aggressively managing chronic stress, maintaining deep hydration, and lowering your overall cellular age actually dictate the ceiling of how powerful your body's regenerative response can be?
So if our own blood is the actual medicine being prescribed.
Then the true maintenance schedule doesn't begin with a yearly calendar reminder to visit an aesthetic clinic.
Right.
True maintenance is occurring right now in how we treat our biological systems every single day, long before the centrifuge ever gets turned on.
If you are going to plant the garden, the soil has to be rich long before you ever sow the seeds. That is serious food for thought. Thank you for joining us on this deep dive. We'll catch you next time.